So I have no disclosures. So you've heard the actual SFA is one of the longest arteries in the body. And it suffers from multiple problems with regard to torsion, to its muscle mass. And so, as I think Scott Stevens said yesterday, it's a very complex biology. And it's not one piece of atherosclerotic plaque across the vessel, it's many types of atherosclerotic plaque across the vessel. And so what that really ends up being is that there's a challenge. And I was asked to talk about complex lesions, and really it's really the many and different parts that make up the patient. And in essence, I'm going to have to bring this down. In essence, the treatment may vary, and it varies for various reasons. One is whether you have rest pain or whether you have shallow ulcers. And in that respect, probably endo is favorable, whether you believe in direct or in indirect angiosomes. If you have a significant tissue loss, which is either gangrene or foot sepsis, whether you go with a Wi-Fi or an appropriate other scale, be it Prevent 3 or the FinVas score, then probably bypass is suitable, as long as there's flow to the foot and as long as you have a target vessel. But in many places, including South Texas, we see more and more people who have no prospect because of a rampant and malignant diabetes that's growing in the population, and they end up with amputations. And those factors have come back and come back each time that people have seen, which is that diabetes, renal failure, cardiac disease, obesity, age, the patient's physical function, whether you talk about a modified frailty index or the equivalent, are important. Sepsis on a presentation is important. And more recently now, the past intervention history is important. That probably doesn't reflect a problem with the intervention. It reflects a problem with the biology of the patient. The extent of disease, calcification, tibial pedal runoff, and whether there's adequate vein, as Tom just mentioned, is also important. But also, there's another variable. That's the skill set, the comfort, and the training of the provider. And what are the local market forces? Why do you need to use this particular technique? But there are still many options. When you see many options, it means they either don't work or they work equivalently. There's no one magic bullet. And that would be possible if we just think about how the SFA is made up. Long vessel, complex lesions, different people working on it. But if you go to the Hitchhiker's Wise Guide to the Galaxy, we are stuck with technology when really all we want is something that works. Or you might, as Peter and I mentioned yesterday, you might have considered that we just found 10,000 ways that many things don't work, and we're getting closer and closer to the point that makes sense. So there are two roads to take. One can take the standard road, or as in Robert Frost's opinion, there are two roads that diverge in the wood, and I took the one less traveled. So let's take a look. The spectrum of disease goes from task A all the way to D. Underneath that is the patient, the lesion, and the extremity, and each have a bearing on the effect of the SFA and its complexity. The second is whether it's de novo disease or recurrent disease. The third is the technique that you wish to choose or the platform that you're most comfortable with. In the new world, cost is important and benefit to the patient is important, and eventually meaningful outcomes that we believe are important, whether it's quality of life, if it's claudication, it should not be loss of limb. Those are all important things that we need to think about. Everybody's familiar with the task classification. In the old days when we first started doing this, C and D were dreadful. People would get up and say that you were insane, or even if you go to Legally Mind, they'd probably sue you for doing a C and D lesion. That's probably changed significantly now. We also narrowed the scope of what we would consider good prognostic factors and poor prognostic factors. That's also changed because technology has improved, training has improved, people's expectations have improved. But if you look at secondary patency, vein is still superior. Endo is now better than prosthetic, perhaps except in Dallas where they get equivalent patency in their particular studies on a randomized basis. But in the early years, it comes out close to being the same. Many people have advocated a set of algorithms for your tasking, from drug-eluting balloons to atherectomy, to drug-eluting stents, to regular stents, to even this thing called surgery. But the first thing to look at is the patient. And for claudicants, you will get a good result irrespective of what you use, provided you have the competence. For rest pain, open will generally be better, provided you don't kill the patient, as will tissue use. But on its own, patency or the technical aspect is not enough. Did you make a hemodynamic improvement in the foot? If you do, you have success. If you do not, you may not. And the difference may well reflect the difference between inline flow and non-inline flow. Diabetes definitely does affect the outcomes, but it affects the patient-based outcomes, not the technical outcomes. And this again reflects the disease pattern in the patient. Metabolic syndrome, the combination of diabetes, obesity, hypertension, also has an effect. A lot of this is not driven by the other portions of metabolic syndrome, but merely it's another label for those people who are pre-diabetic, who also have significant issues. Similarly, if you look at just clinical success, that is the absence of recurrent symptoms, you'll see the same pattern. Renal disease, as it grows in society, part of it driven by obesity, part of it driven by diabetes, will also have an effect. So if your system does an estimated glomerular filtration rate, not every system does, the further you go down in the stages of renal disease and before you hit dialysis, it will show a disimprovement in limb salvage. With hemodialysis, you will get a decrement both in your endo and your open. And this doesn't reflect technique, it doesn't reflect the optimal therapy, it reflects the biology of the patient that you're attempting to treat. Most lesions have length calcium, they may or may not have clot, they often have a cap. You may be going intraluminal or extraluminal, and you need to know if there's a response to the intervention. Has there been recoil, dissection, perforation? All these things will affect you. In general, if you look at the guidelines for the OPGs from the SVS, if you identify people who have clinical risk factors, you will have less clinical efficacy. If they have anatomic risk factors reflecting generally both the leg and the patient, their outcomes are significantly worse. In general, however, most studies will suggest, and you can see here whether you use a true stent or a covered stent, the longer the lesion, the more problems that you may end up having. Protect also suggested that moderate or severe calcification, total occlusions, a filling defect, irregular lesions at 20 millimeters, and soft or non-ulcerated plaques can lead to distal embolization, a fact that you may not have thought about since you were concentrating merely on the SFA. And it does go with the technique that you're going to choose, whether it's a simple balloon angioplasty, or you're going to use a stent, you're going to use one of the atherectomy devices, or you choose to use an energy-based device such as a laser. But what does that mean? What it means is that you have markedly reduced freedom from recurrent symptoms. Those people who get distal embolization do very, very poorly. They also have a diminished limb salvage. But what about the extremity? Well, in general, you can look at your tibials and you can take the reporting guidelines from the SVS that are recently published, which suggest that you can look at an idea of impedance within the limb, and it goes to about 15. And if you take each of the ones that might have good runoff, compromised runoff, or poor runoff, you get a little bit of change in your primary patency, but a significant change in the patient's problems with more recurrent symptoms as that runoff reflects. This reflects both the anatomy of the leg, but also the biology of the patient. And similarly, if you want to look at recurrent symptoms in critical limb ischemia, it's even markedly worse. Target revascularization is important, not perhaps because the cardiologists use it and we should not use it. It merely has a very good proportionate tie to the cost of the total cost of care of the patient that presents to your healthcare system. So the lower your TLR, the more money you're going to be spending for that patient. whether you decide or not to intervene on the tibials, you will always have a better run. On the left of the slide, you'll see far better anatomic variance, but still no significant change in the patient objective performance goals, strongly suggesting again that biology is trumping whatever we can do in the SFA. What about de novo lesions? Well, we do pretty well, both with endo and open, and so endo has caught up. Remember the first slide I showed you where that open was so much higher. The technology is working. We are getting there in those patients that we select. Now, a long, long time ago, John Porter published a paper, and he strongly suggested that if you intervene on a patient, you actually light a time bomb in the distal vessels and tibials, and that their runoff markedly decreases, and that this occurs within 5 years. So if you tackle the SFA, it may be the gift that keeps on giving. It just may be the gift that keeps on giving for the tibials. And in essence, what people have seen is that when you have recurrent disease in the popliteal, early failures do often predict worse outcomes. And this paper from the Brigham, as you can see from the black and the red lines, strongly suggests that this is a very bad model. Again, it's not the technique, it's more likely the biology of the patient that we may need to adjust. Our own work suggests that if you find patients who have had a markedly decreased in their tibial runoff, or their lesion has become worse, and you choose either repeat or bypass, you will get about equivalent outcomes. But in those people who re-present with recurrent disease, it's probably not a wise choice to just go slam back into an endo first policy, because they may be declaring, particularly in the early failures, that they have bad biology. They're telling you you need to do something else. You can follow Einstein's law, right? If plan A doesn't work, do not continue to do plan A. You need to think about a second plan B. Our summary was suggested that for recurrent disease, it's always extensive and it's associated with superior long-term outcomes if you do bypass. What about techniques? Everybody's talked about techniques. So it does appear that in many people's hands, PTA and bare metal stents do markedly diverge with time, and that bare metal stents appear to have a slight superiority for larger lesions. It is true that the silver PTX, as an example of a drug-eluting stent, appears to have superior performance to the bare stent. It is also true, from Claudio's talk yesterday, that covered stents also appear to have a marked superior patency in controlled trials. Drug-eluting stents, both in the primary and in the recurrent issue, appear also to be superior when it comes to treating a disease. If one wants to take a different way and can't get through antegrade, you could try the retrograde popliteal technique. And you can do the full range of interventions, perhaps not with the laser, with an 88% success, and this helps you with your de novo range. And while you get a very complex disease, which is TAS C and D, you end up with very minimal morbidity and quite a successful amputation-free survival. So just by virtue of the fact that the antegrade approach does not work, the retrograde is still an acceptable use of your technique, provided you use ultrasound. And Scott Stevens showed us both the popliteal and the tibial yesterday when he was here. But stents have issues, and the one that's most interesting is probably the stent fracture. It has significant issues depending on the style of stent that's used. Now, wall is not commonly used anywhere anymore, but as a good proband, it shows that the more rigid and less nitinol in the stent, the worse it becomes. It's interesting, however, that exercise habits affects your stent. So in other words, I get you in your claudicant, I put a stent in, and I tell you to walk, you're highly likely to break your stent, which will then give me restenosis, and you'll be the gift that keeps on giving. But the more modern stents have markedly reduced this rate. Supera has reported 0, even the silver PTX is at 0.9. Now, if we move on to the various drug-eluting technologies, it's Achilles heel or it's necessary preparation, depending on how you look at it and from your cost perspective. Both using a drug-coated balloon or a drug-coated stent, you will require some kind of pre-treatment of the lesion. Financial modeling on drug-coated balloons show that the pre-dilatation, and I'll show that later, can often lead to a significant problem with costing in the hospital, particularly as bundle payments continue to increase within the vascular domain. But in general, from the IMPACT trial, you can see a relatively successful implementation of a drug-coated balloon in the SFA. Published more recently is their 2-year results, which Peter was a part of. He's on that paper. He could probably speak better to it in JACS. And I would share Tom's interest in this very interesting meta-analysis that appeared with the beautiful pictures that strongly suggested that as we look through things, drug-eluting stents are more important. But the one weakness in the study was that there was no drug-coated balloon. And so perhaps we're not is even, as a meta-analysis, behind the times as to where a lot of us are or will be going in the near future. It's important to realize that drug-eluting balloons do reduce your risk of TLR. And if one links TLR to the total cost of care, then that's important. What about cost? Well, this is hospital margin, so the less the column, the less the hospital makes. And just for the hospital margin per event, in the current pricing structure, of course, standard balloon angioplasty and even the standard stent, because of the way they're composed in your group purchasing scheme, will be about the same. Drug-eluting stent is a little less, and the drug-coated balloon may be more. A portion of the drug-coated balloon issue is what you use for your preparation of the zone. And so again, we come back to how the operator works and what they're comfortable with. But if one ties TLR to the total cost of care, that is the need to re-intervene in 1 year as opposed to just the episode of care that I showed you, then it seems likely that the drug-coated technologies, be it a stent or a drug-coated balloon, are superior. But the SFA is unforgiving. And even Endovascular today, which pioneers a lot of the early stuff that people see, it's not peer-reviewed like a lot of the stuff that Tom showed, they still have issues with evolving technology in the SFA, how to treat in-stent restenosis, and how should we manage our drug elution. Because we're not perfect with drug elution yet, and maybe we don't have the perfect drug yet, but it's going in that direction. So how do we manage it? Well, we still do an angiogram, we still have an endo policy, and we still do retrograde interventions. But we're moving a little bit more to the patient who has good risk and has vein, and intervene perhaps a little bit earlier. A portion of this is related to the population that we see, but a portion of it's also related to the fact that as we look through this portion, particularly if they've already had one kind of endo response, perhaps using Plan A and continuing with Plan A is not successful. And so we're seeing ourselves move back towards a more aggressive, open approach as long as it keeps the patient as inline flow, direct angiosome if you truly believe in it. We do recommend preserving the target vessel and not being exuberant to get down too far. Maximize the quality of life. And in our current situation, either for the various hospitals that we work with, we also have to contain costs. So I will leave you with one comment, which is judge a man by his questions rather than by his answers, and hopefully I can help